Coming up on the program, why do so many women still know so little about their own health? We begin with the surprising and sometimes dangerous gaps in women's health knowledge and the urgent need for better education. Then we shift to the front lines of critical care, where advocacy becomes life-saving, especially when patients are just too young or too ill to speak for themselves.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at americanbrainfoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
From the moment we're born to our last breath, every American embarks on a journey through the intricate maze of the healthcare system. These are their stories, one life at a time. Today, we meet typical patient Priscilla. Priscilla is a 56-year-old marketing executive who kept forgetting words during client calls. At first, she laughed it off, stress, maybe menopause. But then she got lost driving to her own office. Her doctor chalked it up to burnout. Months passed before anyone considered testing her memory. By then, the damage was done. What's Priscilla's diagnosis? Hi, I'm Dr. Joe Servin, a practicing neurologist at Mayo Clinic, professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Now let's turn our attention back to Priscilla. The diagnosis is Alzheimer's disease. It's a diagnosis that disproportionately affects women, but many still believe men and women are equally at risk. That's just one of the surprising findings from a new Cleveland Clinic survey on women's health. To walk us through the results and what they say about our collective blind spots, we're joined now by Dr. Claudia Mason. She's a physician at the Women's Health Institute at Cleveland Clinic in Florida, and she's going to help guide us through some of the results of the study. Dr. Mason, welcome to our program.
Thank you, Dr. Servin.
Let's start with the survey itself. What prompted the Cleveland Clinic to take this deep dive into women's health knowledge in the first place?
The clinic just opened within the last year a Women's Comprehensive Health and Research Center, and they were getting baseline information from what women's perspectives are and their knowledge base so they can manage part of our mission, which is education.
One of the most surprising findings was that nearly 2/3 of Alzheimer's patients are women, yet a third of the respondents thinks it affects men and women equally. Why is that misconception just so persistent?
I think there is a general lack of information and understanding of chronic illness and how it affects women and men differently. We have had little participation as women in health studies, and we also don't have lots of time for discussion with our physicians to get to that point of knowledge.
Another one that caught me off guard is that stroke is more common and more fatal in women, but 31% of women, a third literally, just don't know that. What do you think is behind that blind spot?
I think when we consider stroke, we're kind of lumping it together with heart disease or circulatory diseases. And the specific information about stroke and how it disproportionately affects women is really lost. We worry about our cholesterol numbers and we worry about our blood pressure, but they don't really put us to the final end of what could happen if those are unchecked.
The survey showed that a third of women don't know enough about menopausal hormone therapy to even form an opinion. Um, how do we fix that education gap? We cover that topic a lot on this show, and it seems like it's something that we always seem to have to double down on. But it seems like that gap just seems to always be there.
Yes, there's been essentially a generation gap for physicians um, not having the information that they need to be able to pass along to their patients. The Women's Health Initiative study came out roughly 20 years ago, and physicians who are now in their mid-career were dissuaded at that time when they were in their training from any type of menopausal treatment or education. And so it's difficult for them to pass along what they don't know. Um, Again, in many cultures, these are bits of information that are passed along from mother to daughter or within families. And so, what one woman knows, another woman may not know. And so, we have this fairly large gap in information. And then there are taboos about discussing anything that has to do with reproductive health in some cultures.
What do you think these gaps in knowledge tell us about how women are receiving, or maybe better put, not receiving health information from the people managing them, the ones that they go see, their physicians, their providers, whoever they may be? What do you think this tells us?
For me, it tells that you have to develop a relationship with your patient over many visits before you can basically give them information that they're going to need. And if you're not seeing someone who is trusted, it's a tough sell to give people advice or information. They may not believe you, they don't necessarily trust you. So the relationships need to be built between healthcare providers and their patients, and vice versa, between patients and their healthcare providers. There's a limited amount of information that is digestible at any one visit. So over a period of time, even years, that information can be given when the patient is ready and receptive to health information so that we can give them the full spectrum and understanding of the information and education that they require.
I want you to talk to us a little bit about the methods of the survey. Who were the folks that were discussed, or kind of asked these questions, and what kind of responses? I know we got into some of the factual pieces, but what kind of numerical responses did they get in terms of the number of folks that responded?
Well, there were 2,100 US women, and they were aged 18 and older to respond to the questions that the clinic and YouGov proposed. They were adjusted and matched the population of all US women and were uh, sub-segmented into age, educational status, and economic status. And that was something that was very interesting to me, to see that lack of information or access to care or other issues was pretty much across the board. Um, Age didn't matter as much, educational status didn't matter as much, nor did ethnicity.
When you see these results, I'm just wondering, what when you saw what came out of it. I've shared with you where I thought was kind of interesting, but were there items or gaps that really hit you personally that said, "Oh my goodness, this we really need to do better about this"?
Well, the interest that women have in participating in clinical trials was certainly an eye opener. At least about a third of women across all segments were interested in participating. And that's important because we need that information to be able to give better medical advice and get better data about treatments, diseases, and health in general. Then the other piece that I just mentioned, that there was really no difference across segments for women when they said they had where they got their healthcare information. Most women got it from their primary care doctors across the board. Most women also had multiple knowledge areas from either online or books or family and friends. And that was a good quarter of women got their information from family and friends.
Wow.
So that was across the board. So that was a very interesting statistic for me. The other piece was that a good quarter of women have no clue how to manage their, their life and health in midlife and beyond. That they were
Wow.
pretty uncertain about how to manage that, and that's a big area for opportunity.
One of the things that seems to come up a lot in our current discussion is that it seems that a lot of people, maybe it's the skews younger, but I'm just wondering what your thoughts are on this, or whether the survey touched upon it, is that a lot of times, a lot of social media seems to fill the blank for kind of health information. And that seems to be true in both men and women. And I'm wondering, did the survey touch upon any of that at all, or not so much?
It did. It did. And as expected, 17% of 18 to 34-year-olds used social media or online communities to get health information, whereas only 5% of women over 55. So that would be expected as they are more facile with the use of social media. Um, 77% of women over 55 got their information from their primary doctor. But again, a good 52% of women used multiple sources, including online resources.
And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin, and if you're just joining us, we're talking about women's health and what women know about it. And we want to hear from you. If you have an idea for future shows, tag me on social media at jservin. Dr. Mason, do you think women, when you think about the totality of this, do you think they're being underserved in traditional health conversations? They're just not being encouraged to ask questions. I'm wondering, to kind of get into the meat of why we think we're seeing the results we're seeing.
Well, Dr. Servin, I think it's really difficult to take an entire semester's worth of healthcare education and stuff it into a 15-minute visit.
Amen.
Um, that's why I mentioned previously that relationship with your provider is so critical, because you may be able to get small bites for patients at each visit over time. So that my approach generally for a patient visit is yesterday, today, and tomorrow. Going over what their prior history says, what their current issues are, and then preparing them for the next step. That's giving them little manageable, digestible bits of information. Obviously, in the today part, we answer their questions and address their current concerns. But again, I try and anticipate what their needs will be and get them ready for the next step. That's, again, only in small bites, because most people are a little bit anxious when they go to the doctor. They want to know they're okay, or they want to address their current issue, and then getting extra healthcare information put into the visit is just a little bit of icing or the cherry on top for that visit.
How much responsibility lies with the healthcare system versus media, public health education. There's always seems to be a lot of finger pointing. It's either too short visits, too much social media intrusion. But specifically to the system itself, how much do you think is that system kind of responsible for just these huge deficits in knowledge?
Putting my public health hat on, I would say that it is very important for the healthcare system to be advocating for preventative health, making sure people are aware of the factors that influence their own health and their family's health, so that we can do that education from what patients essentially considered a trusted source, their physicians. Then, when we move on to the media, as a child, I remember watching television and seeing public service announcements saying the 7 warning signs of cancer. And that taught me what the 7 warning signs of cancer were when I was a child. So I knew about that.
Right.
We don't really have a lot of that. We used to have a little bit. I see less and less of it as time goes on. But public service, where the media can then give information that is reliable and truthful, is very helpful because it does hit a mass market. Nowadays, we do have the internet and we have social media, but I don't see public service announcements in those spaces. Then patients really are sort of responsible for their own health in many ways and asking questions. I do know that there are a lot of shy folks out there and they like to be good at the doctors. They don't want to rock
That's
the
right.
boat.
That's right.
And so that's right. They want to get an A.
Yes.
And so they typically will put away their questions unless the physician specifically elicits and asks about anything else, or do you have any further questions, or what are your concerns today? So if you ask those questions, you tend to get more answers than you really want to hear.
Right.
But on the other hand, those are important because you do then address the actual issues that the patient has in the back of their mind, and you can get them ready for that next step.
I'm smiling because I always think of I remember my own mom who would make sure she dressed up for the doctor, and I said, make sure you tell him that. I go, I don't want to disturb him, and I'm like, well, that's why you're seeing the doctor. So I'm curious, what's the best way to empower women or men for that matter to speak up and ask more questions during, as you said, these 15-minute visits?
I encourage people to write things down, and that's very important. Because people are shy, because they're going to forget, because other things will come up in conversation, they won't have all of their issues and questions asked unless they write something down so we don't forget to address that. Sometimes it's going to take more than one visit to get through everything, but that's reasonable. And we want to make sure that patients feel heard and that we will address these issues as in a reasonable fashion. So I ask them to please write it down. In the Cleveland Clinic, we have something, has a patient, and I'm sure Mayo has this as well. You have the my chart, and it has
Sure.
the ability to message your doctor. And I get a page full of messages every day from people asking questions. And, you have to be open to answering questions that, sometimes to me seems pretty self-evident,
Right.
but it's not to the patient. And then, they are looking for answers from a trusted source. So I'm very flattered to be considered that trusted source.
How can we start these conversations earlier, before symptoms show up, like in the case with Priscilla in our intro here, to prevent a bad outcome later?
Oh, that's a good question. I've been pondering this myself.
Sure.
Obviously, having a primary care physician that listens and pays attention is important, and elicits the patient's participation in the visit, so that when disturbing symptoms come up, They're not just put to the side as, oh, it's menopause, or, oh, you're just stressed. But, actually is listening to what the patient is telling them. If that were me telling my doctor that I'm becoming forgetful, that's because I'm frightened to death. And so by the time somebody says something like that to you, this is a big worry for them, and these things need to be taken seriously. So from both perspectives, the patient needs to bring it up and the physician needs to listen.
In our last moments here, if every listener took a small step to improve their own health literacy, if you will, what they know about their bodies, their health, what would you want that to look like, or that to be? What's a simple step for our listeners out there?
I think writing down their questions, their queries, what they heard on their social media platforms, and validating that with a trusted source. Those are important things so that your knowledge of your own body, its functions, becomes part parcel of what you do for your own self-care to make sure that you're living your best life.
Because there are so many sources of information out there, Dr. Mason, are there any particular sources that you recommend when people want to find out good information that's reputable and accurate, so that they can apply it for their own lives?
Well, I usually tell patients, well, I'm going to the library when I have some questions, and I look it up. And then I'm looking at, the medical literature. Now, I realize that that's a big ask for patients, but not to get somebody's opinion without some qualifications, to be critical of where they're getting their information and making sure that it is going to be a reliable source, not just somebody's opinion because they have so many followers or whatever. That there is some qualification behind that. So that's what I tell patients. I go to the library and I look things up and I look at what the various what the issue is, and from various points of view, so then I can make my own decisions or form my own opinion about this, but based on fact rather than on somebody else's opinion. I do understand that opinions from other people are very influential, and that is an important thing to take into consideration, since most people are going to either get their information from their physician or from friends and family.
I want to let you have this moment, Dr. Mason, to address our listeners, if you will, with any last bits of advice or wisdom that you want to impart from this survey, or in general as they search for their better health, if you will, through the healthcare system.
I would ask patients or ask people in general to advocate for health education starting in the schools, and that it also continues as part of your adult learning, so that you don't feel left out, you don't get blindsided by lack of information, and you use the trusted sources that are available to you.
I think that sounds like perfect sage advice. Dr. Mason, I want to thank you so much for giving us your time today. I know you're super busy, and just appreciate all your insights.
It's been a pleasure.
We've been talking to Dr. Claudia Mason. She is part of the Women's Health Institute at Cleveland Clinic in Florida. Coming up after your health headlines, advocating for those who are voiceless in the healthcare system. Stories from the neonatal ICU. And we'll be right back. Hey, it's Dr. Joe Servin. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media.
Hi, I'm Stacey Bennett, producer of What's Health Got to Do with It, and these are your weekly health headlines. The U.S. has recorded more measles cases in 2025 than in any year since the disease was declared eliminated in 2000. With close to 1,300 confirmed cases and 3 deaths, 2 children in Texas and 1 adult in New Mexico, the resurgence is fueled by falling childhood vaccination rates and a massive outbreak in under-vaccinated West Texas. Gaines County, where nearly 1 in 4 kindergartners lacked the MMR vaccine last year, has seen over 400 cases alone. Outbreaks now span 38 states, with cases linked to air travel and international hotspots in Mexico and Canada. Public health officials warn that continued spread could threaten the nation's measles elimination status. According to a new study in JAMA, the health of America's children has dramatically declined over the last 15 years. Children are 15 to 20% more likely to have chronic conditions like depression, anxiety, obesity, autism, and ADHD. Alarmingly, children in the U.S. are now 80% more likely to die than peers in other wealthy nations due to higher rates of sudden infant death, prematurity, gun violence, traffic accidents, and substance use. Experts link the decline to gaps in healthcare coverage, with 41% of children relying on Medicaid. Recent cuts to Medicaid and public health programs may further widespread disparities, and researchers believe systemic change is needed to reverse these trends. A new survey shows 75% of Americans are prioritizing how they feel over how they look. Over 3/4 of respondents believe gut health affects emotions, and that emotional and physical health are deeply connected. For many, this inside-out approach to wellness involves mindful habits such as intentionally getting better sleep, eating nourishing meals, engaging in joyful movement, prioritizing time with friends, and saying no to draining commitments. Another trend is the use of probiotics, which can improve digestion, mood, and sleep. Experts say this mindset marks a shift from chasing perfection to building long-term well-being. And for some good news. For the first time, newborns and babies weighing less than 11 pounds now have an approved malaria treatment. Swiss medical authorities authorized the use of Coartem Baby, a drug designed for infants as light as 4.5 pounds. Developed by Medicines for Malaria Venture and Novartis, it fills a critical treatment gap for one of malaria's most vulnerable populations. There were 263 million reported malaria cases in 2023, causing nearly 600,000 deaths globally. 76% of those deaths were among children under age 5 in Africa. The dissolvable, cherry-flavored formula can mix with breast milk, easing delivery in low-resource settings. Rollout is planned in 8 African nations where the treatment will be introduced on a nonprofit basis in places where malaria is endemic. And those are your weekly health headlines.
Welcome back to What's Health Got to Do with It. I'm Dr. Joe Servin, and we now pivot to how advocacy becomes life-saving in critical care, especially in patients who can't speak for themselves, such as in a neonatal ICU. Let's meet baby Stina. Baby Stina arrived 10 weeks early. She struggled to breathe. Her mother, recovering from an emergency cesarean section, is told little. Only that things are stable, in air quotes here. Over the next few days, baby Stina undergoes multiple procedures, but no one's explaining why. The parents feel powerless, lost in acronyms and alarms. It's only when a neonatal nurse practitioner steps in to translate and advocate that things begin to make sense. what's going on here? The diagnosis for baby Stina is that she had a premature birth with respiratory distress syndrome. And in the chaos of the neonatal ICU, or otherwise known as the NICU, it's easy for families to feel invisible. That's where patient advocates, especially those in critical care, become the voice for those who can't speak and the bridge for those trying to understand. Joining us now is Julie Hatch. She's a neonatal nurse practitioner who's been that voice for countless families. She's also the author of an exceptional medical thriller called The Very Best of Care. I totally recommend this one if you're looking for a good summer read. And joining us now to talk about how to advocate when the patient is voiceless is Julie Hatch. She joins us from her home in Massachusetts. Julie, welcome to our program.
Hello, Dr. Joe. Thank you.
You're very welcome, and we are so happy to talk to you. Julie, you've worked in some of the most emotionally intense settings in healthcare. I'm talking about neonatal ICU and other similar, very acute and critical care areas. How did you become involved on the other side of this, which is patient advocacy in the world of critical care?
Well, as a professional working in that environment, you have to be an advocate for the parents and the patients. As nurse practitioners, we work very similarly to what third-year residents or fellows do. We do a lot of medical stuff, but yet we're also nurses. And I think many parents would say that nurse practitioners are a little bit more accessible in terms of being able to talk to. So we're sort of there to bridge between delivering the medical care and giving the comfort and compassion, and communication is one thing that's huge that you alluded to the parents. So we're kind of there bridging both areas.
That story that I talked about, baby Stina and her parents, how common is a story like that? Is that an unusual occurrence? Talk to us about that piece of it.
No, that is not. I was smiling. I mean, it's very unfortunate, but the way that it was told, that is exactly what happens. The neonatal ICU, especially when a baby is first admitted right after birth, is sometimes it's just a zoo. There's a lot of noise. There's a lot of people. There's just your tiny baby in the middle of all that is just having tests done and lots of discussions over the baby. And it's overwhelming for parents. There's no doubt it's absolutely overwhelming for parents. And even the most bold parent who would, say, "Excuse me, can you tell me what's going on?" will still might get railroaded, all because they're trying to save her baby, but nonetheless don't always have time to sit and talk with them until things calm down, or either a nurse for the baby or a nurse practitioner or a social worker has the time to come and talk with them. Oftentimes it's not the doctors who are the firsthand people with the knowledge. They often are not available, or they don't make themselves available. There's different people.
Got it. What does advocacy look like in those moments when the patient, maybe an infant in this case, or someone on a ventilator and they're an older adult or any aged adult? What does advocacy look like kind of on a practical scale in these moments?
Advocacy, I would say, is being the voice for the person that can't speak for themselves for whatever reason, whether it's a baby or somebody who literally can't speak, and being their voice. And it's tricky to be that voice because you need to make sure that you are representing that person accurately. And so advocacy is speaking up for that person, being the ears for that person, which often when you get information from a doctor, a parent certainly may not understand it and may not hear everything. There's just too much coming at them. So the advocate can also be the ears for the parent and then translate what is being said to them. So advocacy is, like I say, just standing for the people that can't stand for themselves for any number of reasons, or speak for themselves, stand or speak for themselves.
People in your role as a nurse practitioner in that setting, you're trying to balance that medical team's urgency with the family's need for clarity and calm. How do you thread that needle?
It's hard because absolutely my first priority is to keep the baby alive. And a lot of times parents get pushed aside or moved aside so that people can save their babies. But there needs to be humanity in a crazy place like a NICU. And humanity is what the parents deserve. So does the baby, but the parents deserve some compassion, some humanity, because I mean, that's really what it's all about. Saving a life is first what it's all about, but very, very close second is doing that with some compassion and humanity, and respecting and honoring the people that you're dealing with.
Practically speaking, let me follow up on that. What does compassion and humanity look like in that setting then? I mean, as you said, the primary thing, save the baby's life. But what does that look like?
Compassion is a close second because it means that you're able to put yourself in the parent's shoes. And as a parent, although I never had a baby in the NICU, I still had 3 children. As a parent, it was a little bit easier for me to put yourself in the parent's shoes and try to understand what they're going through, which isn't always easy to do, but understanding what they're and then acting accordingly with that understanding of what they must feel like, what they are going through, acting accordingly, reaching out to help, to say, what can I do? What do you need? Offering a shoulder to cry on, whatever, open up your heart, which is something, and that's the humanity, I think, is opening your heart, which, again, it's not the first thing that happens in a NICU, but it needs to be a close second, I think.
We talk so much on this show about just, the issues surrounding our health system. And I'm wondering, in this circumstance, is there resistance from within the system when you try to advocate for the patient or the family? What does that resistance, if it exists, look like?
I think that no, I don't think that there's resistance to advocacy. For instance, if the higher ups or if administration, you need to go to administration about what's happening with baby, which doesn't usually happen. I think that usually people, all the professionals are pretty much on board with each other. The parents may not be on board in the same way, in which case then it does need to be addressed, and communication is number one there. And as the worker bee in the NICU, I didn't have a whole lot of interaction with administration. If I did interact with administration, it usually did mean trouble. So there is the administration who sits in their offices and, I don't know, makes decisions, whatever. And then there are the rest of us are the worker bees. But working in the NICU with the doctors and the residents and the nurses, we are all pretty much on board together. So it's kind of easy to come as a united front to help the parents.
We so often think of advocacy. Most people, when they hear that word, they immediately think legal or they think political or policy. But can you give us maybe a better sense of what that looks like in the setting you're describing? Maybe give us an example.
This is a really kind of a minor example, but it's very present.
Sure.
Nurses try to minimize how often the really little premature babies that are stable, but still very, very sick. Nurses try to cluster their care so they disturb the baby only once every 3 or 4 hours rather than hourly every 3 or 4 hours. It's really important for the baby to have rest. You just touch them and they can start to have breathing problems and they're that unstable.
Wow.
So, for instance, if a parent comes and only has, I have to get to work, I really want to go in and talk to my baby and touch him just for 5 minutes. And the nurse may say, no, we're sticking to this. And this is the way it's got to be, whether it's around touching the baby or clustering their care or whatever. A nurse may say, no, this is the way that it's got to be. So somebody needs to step in and be the advocate for the parents, which is kind of like an ambassador almost in this situation, and try to help each side to understand each other and work towards a common good for the baby, which is what we're all ultimately there for. I don't know. Does that make sense?
It does make sense. I mean, I guess maybe I'll frame a question in this way, I think in a very practical way for those listening. How can families advocate effectively for their loved ones especially when they're the ones who are terrified, they're unsure, they're not medically trained. What would you say to these families and folks if they find themselves in this situation?
Well, when they initially find themselves in this situation, it's really hard to advocate because you don't know what the heck you're advocating about or for. You
Right.
just want the best for your child. And you're putting your complete faith and trust in the system, in the doctors and the nurses. So initially, I think there's not a whole lot of advocating, assuming that nothing's being blatantly wrong. And then as time goes on and you start to have questions and you're wondering, what is this all about? And explain the equipment and the medications and all of this. You just have to speak up for yourself, even if it takes setting up an appointment with a medical team, and having a family meeting, which happens frequently in the NICU, a family meeting where you have all your questions answered, you can speak up, and to get away from the bedside, out of the NICU and into a quieter room where you can have meaningful interaction with the medical team. But you have to step up and ask for that. And there's nothing wrong with that, to step up and ask for a meeting, communication. So many doctors have said to me that, especially the really good ones,
Yeah.
that communication is, even when the medical system or the doctor messes up, and to go to go to the parents and communicate ahead of what might happen is so important, and prevents so many problems down the road if doctors just communicate from the beginning. Even if it's bad news about their baby, to communicate it up front. Parents would usually rather be told the truth.
Right.
And so that's about, I guess that's more about communication than advocating, but communication is certainly part of advocacy.
You got it. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin. And if you're just joining us, we are talking about how to advocate for voiceless patients in critical care. And we want to hear from you. If you have an idea for future shows, tag me on social media at jservin. Let me kind of give a nuanced question, if you will. You just described how advocacy, communication plays out. What about in the setting of, let's say, the family does not speak the same language as the team? Maybe they're from another country for whatever reason, or culture. They're a different educational level. How do you see those scenarios playing out when it comes to advocacy?
They have every right to understand what is going on as anybody else. So if it's a foreign language, if you're in a NICU, it's probably a big hospital, and they have translators. And even if there aren't translators in person, there are always translators at services that you can get by phone, because you can't. Whatever you're telling them is not informed information if the people don't understand what you're saying. So they have to understand you have to speak the same foreign language, or have an interpreter interpret the language. As far as educational level, it's up to the practitioner and the medical staff to speak to the educational level of the parents. And that's why often I think that social workers get really very involved in all these babies, but in situations like that, the social worker will be really tuned in to how much the parents are, and I'm just saying parents, the family, how much they are understanding. And we can when we're talking, we can sort of understand how much they're understanding, but the social workers are there to actively say, okay, they don't understand. Let's speak for them. Let me speak for them, or let's try to get to the understanding that they can get. So there's always a way to make yourself understood, help the parents to completely understand, because if they don't understand, then it is not informed consent to even being in the NICU. And that's really obviously very important.
There are listeners out there who may find themselves in a medical crisis in the future, near future. I mean, I hate to think about it, but it's just true. What's one thing that you would recommend these folks who find themselves in that scenario that they should ask or do that, as a matter of course, could really change the experience?
Well, I think of myself, if I was ever in that situation, is I would make sure that I would have somebody with me. I don't, I do care who it is, but I would have somebody
Sure.
with me as my advocate who can speak for me and can listen for me and help me go through the experiences. So if you have that person with you, what you want that person to ask for you is information to know what exactly is going on. Nobody has a crystal ball. They can't tell you what is going to happen, whether you're going to live or die, whether you're going to be sick for years or months or whatever. Nobody can tell you that. They can give you an educated guess, but especially in the NICU, you just never know what the outcome is going to be, and so that's okay. But to know from moment to moment what is going on, what to expect perhaps tomorrow, or what tests are coming down the pike, to get as much information as you can from the doctors or nurses or nurse practitioners that are treating you. One of our things when I worked in the NICU is that people would always go to Google
Yeah.
WebMD
Oh,
and
yeah.
find their answers there,
Oh,
and
yeah.
that's not recommended. So to go talk with the people that are dealing with you, dealing with your child, and have a conversation about you, about what the situation is at hand.
We talk so much also on this show about burnout and things of that sort, and this is a very high stress work for people in your position. And I'm wondering if you could share what keeps folks like you going in this work. What was your angle of, like, because you've done it for so long? What keeps you going?
I always loved intensive. I've always loved working with kids. And I've always loved intensive care. The adrenaline and the things that you learn every single day. You never know what you're going to walk into. It was always an exciting job. New things happening every day, new parents to meet, new colleagues to talk with, new scientific information and technology coming down. There's always so much going on. It's fascinating. It's always never a dull moment. And often people will say, how can you take care of these poor babies? And especially when something very, very sad happens, which of course does happen, but much more often than not are the happy outcomes and the babies that leave the nursery and go home with the parents. And then we end up seeing them when they come back for follow-up clinic and they're like happy little 2-year-olds. So the outcomes are just outweigh the unfortunate, sad outcomes. So those are the fascination with it and the happiness, which eventually, ultimately, usually happens amidst all of that other stuff. But I did definitely get burnt out. And I went through periods. Everybody goes through periods, and you just sort of have to figure out a way to take a break or step away or go to a less intensive, like the step down unit or something like that. But it is a high burnout area. But you got to figure out what keeps you there and tap into that.
I love that. I'm going to flip to a different topic with you. As I mentioned earlier, you authored a medical thriller set in a neonatal ICU called The Very Best of Care. And as I mentioned to you offline, my wife and I fought over your book because it was just such a page turner. Why a medical thriller? I'm curious what got you going to write a book in that vein?
Because I lived it for so long. The NICU and the PDIC, but much more the NICU, I feel like it's in my veins. It's just there's been so many experiences. I've loved it. And so there's a lot of kinds of stuff that came out, and there were a lot of the book is based on real experiences of mine and real stories. All of it is fiction, but it's what I have absorbed over the many years of working in the NICU. And I love reading medical thrillers too. Robin Cook is one of my favorites.
It's so funny you said that. I kept thinking of that, and I am not going to give out any spoilers here, but I do want to ask, I'm like, one of the themes is just the intrusion of, let's just say, big industry in medical care. And I'm wondering, is that, as you just said, you saw a lot of stuff happen. Is that, I mean, is it based loosely on reality, or how would you describe that without giving anything away to those who want the pleasure of reading it?
It is based loosely, I would say, some of it. There was part of it about an insurance company doing some rather unethical testing. And that's not, I could see it happening, but that's very unethical. And I never did see that happen. Big Pharma, I think that Big Pharma there's a lot to be said for medications, especially in intensive care and in acute settings. But in this book, they were preying on the feelings and emotions of parents, which again, wasn't done, but again, I could certainly see it. I have a little bit of a problem with Big Pharma and what they will do to get your business. So that was loose, but I thought it was kind of poignant.
Fair enough. Julie, I'm going to give you the last word here. I want to allow you the opportunity to address our listeners and, offer any message that you wish on this topic that maybe we haven't talked about up to this point.
Well, interesting that you should ask that, because just before coming on, I was reading the news, and I'm really very interested in what Robert Kennedy is doing about vaccinations. Primarily vaccinations, taking away Medicaid, although children that have disabilities are affected by Medicaid. And I've written a blog about this. I would ask people to make sure that you are getting your information on your own health, your child's health, public health, whatever the case may be, from accurate sources based on research. I don't know how you can make a medical decision without research findings. So I recommend to people, or I implore people to go to the right sources. And that is, what are the right sources? Sources that are based on scientific research and scientific facts to make decisions about what you're going to do for your child and baby and yourself.
I'm going to let that be our last word. Julie, I want to thank you so very much for giving us your time today. And again, congratulations on an exceptional new book.
Thank you so much.
We've been talking to Julie Hatch. She is a neonatal nurse practitioner. She's the author of the new medical thriller entitled The Very Best of Care. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at wjct.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Luckett. Stacey Bennett is our producer. Brady Corum is our director. Caden Collins is our researcher. If you have any health questions about this or any topic, let us know by calling us at 904-358-6362. Email us at health@wjct.org or tag me on social media at jservin. I'm Dr. Joe Servin, and you're listening to What's Health Got to Do With It on WJCT News, 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do With It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org.
Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com.
And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.